Hello. In this episode, we discuss hypertrophic cardiomyopathy. First, I would like us to understand several categories that applies to the term cardiac hypertrophy by categorizing this into primary and secondary subtypes. The primary myocardial hypertrophy is referred to as cardiomyopathy. The secondary myocardial hypertrophy could be either concentric or eccentric due to pressure or volume overload respectively. So what are the examples of secondary concentric myocardial hypertrophy? Hypertension is the most common, followed by aortic stenosis. On the other side, volume overload conditions such as several valvular diseases or dilated cardiomyopathy give examples of eccentric cardiac hypertrophy. Based on many of the new classifications, these secondary subtypes are not referred to as Based on new guidelines, these secondary subtypes are not referred to as hypertrophic cardiomyopathy. On the other side, the primary cardiomyopathic hypertrophy is divided into symmetric and asymmetric subtypes, and the symmetric type is hypertrophic cardiomyopathy, and asymmetric type predominantly involves anterobasal subaortic septum and is referred to as subaortic or obstructive hypertrophic cardiomyopathy, better referred to as HOCMP. Based on what we discussed now, let us review some of the risk factors of hypertrophic cardiomyopathy. Beginning from infancy, do we have any condition? While hypertrophic cardiomyopathy is possible in many deposit or storage diseases, a famous example of transient hypertrophic cardiomyopathy is seen in infants of diabetic mothers. What's the congenital or hereditary form? Autosomal dominant mutations on sarcomere genes such as myosin binding protein C or myosin heavy chain with variable penetrance. Always remember sarcomere myosin genes in hypertrophic cardiomyopathy as opposed to dystrophin gene mutations possible in dilated cardiomyopathy, for example in the setting of muscular dystrophies, versus eccentric hypertrophy that can be seen in aortic regurgitation in the setting of Marfan's syndrome. Now, if you are asking that eccentric hypertrophy in Marfan's syndrome, what's the gene involved? That's, of course, the fibrillin gene. Do you know any neurologic genetic disease associated with hypertrophic cardiomyopathy? That's Friedreich's ataxia. What are the clinical symptoms of hypertrophic cardiomyopathy? Look at exertional symptoms such as dyspnea on exertion, angina, syncope, arrhythmia, and sudden cardiac death. Mention some of the complications of hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. One is syncope, the other is sudden cardiac death, the other is mitral regurgitation, and diastolic heart failure. What's the mechanism of sudden cardiac death? Arrhythmia. Always remember disorganized arrays of cardiomyocytes predisposed to life-threatening arrhythmias. What are the two important mechanisms of syncope? One is outflow tract obstruction in the hypertrophic obstructive cardiomyopathy, and the other is arrhythmia. What's the mechanism of mitral regurgitation? Or you might well be asked about two possible murmurs in hypertrophic cardiomyopathy, and instead of the holosystolic murmur at mid-left sternal border at Erb's point, which is the murmur of hypertrophy, you may be told that you hear the holosystolic murmur at the apex. And you might be asked, what is the mechanism of that murmur? That is the mitral regurgitation murmur. And then what's the mechanism of mitral regurgitation is a very important point to know, that there is the phenomena of systolic anterior motion of mitral valve due to septal asymmetry towards the left ventricular outflow tract, that's towards the aortic outflow. And this phenomenon itself is responsible for mitral regurgitation, left ventricular outflow tract obstruction, and syncope. Now again, if you are asked what is the most common cause of sudden cardiac death among young athletes, this is hypertrophic cardiomyopathy. Describe the murmurs of a hypertrophic cardiomyopathy. The murmur is diamond-shaped, holosystolic at mid to lower left sternal border, also referred to as Erb's point. But most important factor about the murmur is the fact that it has paradoxical response to both afterload and preload maneuvers. Please remember this statement. By paradoxical response, what do I mean? This is my classification that would help you. By default, every heart murmur would increase intensity with increased afterload or increased preload and drop their intensity by dropping afterload and dropping preload. This single simple statement can help you answer several questions about majority of the murmurs. However, we have exceptions, and I refer to them as paradoxical response, and by that I mean the murmur either softens in intensity, it reduces the intensity in response to increased afterload or increased preload, or vice versa. That's the intensity increases in response to decreased afterload or decreased preload. So what are the exceptions? The exceptions of paradoxical response to afterload maneuvers is aortic stenosis. Aortic stenosis responds to preload maneuvers such as Valsalva, leg raise, diuretics, IV injection, follows the default rule. Increased preload increases the murmur intensity, decreased preload decreases the murmur intensity. However, aortic stenosis responds paradoxically to afterload maneuvers such as hand grip and amyl nitrate. That is hand grip that increases afterload, decreases the intensity of aortic stenosis. Amyl nitrate that decreases afterload, increases the intensity of aortic stenosis. So they are opposite directions. I call it paradoxical response. Mitral valve prolapse is the example of a murmur that responds paradoxically to the preload maneuvers. And hypertrophic cardiomyopathy is an example of a murmur with paradoxical response to both afterload and preload maneuvers. This is also crucial to understand the contraindications for the treatment options when we discuss in a second. Why understanding of the murmur's response specifically to preload but also to afterload maneuvers is important from a clinical assessment perspective and treatment options. Always remember the conditions that make the murmur louder are also known to be associated with worsening of the left ventricular outflow tract obstruction, and therefore any medical intervention or maneuver that makes the murmur louder is considered a medical contraindication. Let's do some exercise on this concept here. Are diuretics recommended for the management of hypertrophic cardiomyopathy? Well, diuretics drop the preload. All other valvular lesions will drop the intensity of their murmurs except for hypertrophic cardiomyopathy, whose intensity would increase. Increased intensity means worsening of the outflow tract obstruction. Therefore, diuretics are contraindicated. Later on, we mentioned that specifically in the obstructive type, they are completely contraindicated. In the non-obstructive hypertrophic cardiomyopathy, they should be used with caution. How about anything that predisposes the patient to dehydration? Dehydration should be avoided because, again, it drops the preload and increases the possibility of left ventricular outflow tract obstruction and risk of syncope, for example. How about vasodilators and venodilators? Vasodilators such as dihydropyridine calcium channel blockers, or venodilators such as nitroprusside and nitrous oxide compounds and nitrates are contraindicated because they increase venous capacitance and hold a lot of blood in the venous compartment and decrease the preload, worsening the murmur and clinical picture. How about antihypertensive medications such as ACE inhibitors, ARBs, or spironolactone? They are also contraindicated for the same reason. How about digoxin? Remember, positive inotropes are also contraindicated for several reasons. One is increase the squeezing power of the heart, increases the likelihood of the bulging of the asymmetric septum into the left ventricular outflow tract. Second is because of the fact that increased inotropy reduces total peripheral resistance by means of reducing sympathetic tone. In other words, it drops afterload and worsens the murmur. Exercise has the same effect, and that's why vigorous exercise is also contraindicated. Please commit to memory these contraindications. Vasodilators, venodilators, antihypertensive medications including ACE inhibitors, ARBs, and hydralazine, spironolactone, digoxin and positive inotropes, vigorous exercise, diuretics. How the pulse of the patient is described. It's bifid and bispherians because there is two upstrokes, one before the obstruction on left ventricular outflow tract and then after it is overcome. Remember, we analyzed this by looking at the carotid pulse. What other murmurs are possible, and by that I mean murmurs and heart sounds in hypertrophic cardiomyopathy? Well, we mentioned mitral regurgitation because of systolic anterior motion. The other findings include S4 because it's a condition associated with impaired ventricular filling and diastolic heart failure. It's also possible to have paradoxically split S2 because the closure of aortic component A2 is delayed in severe obstructive type. What is the best test for diagnosis of hypertrophic cardiomyopathy? That is echo. Describe the findings suggestive of hypertrophic obstructive cardiomyopathy on echo. Dynamic left ventricular outflow tract obstruction, septal asymmetry, dilated heart failure, diastolic heart failure, that's heart failure with preserved ejection fraction. Why we call the left ventricular outflow tract obstruction a dynamic obstruction? Remember that systolic anterior motion of mitral valve, the obstruction happens mainly during the systole, and this systolic anterior motion happens on that stage of the cardiac cycle, so it's a dynamic phenomenon. What are the ECG findings? Left ventricular hypertrophy, left axis deviation, and left atrial enlargement. Also remember the possibility of left ventricular strain pattern. What is this strain pattern once more? It's the presence of depolarization and repolarization, specifically repolarization changes including T-wave inversion and ST depression on the ipsilateral leads. For example, we have these changes in the right ventricular hypertrophy or cor pulmonale and pulmonary hypertension and pulmonary embolism on leads V1, V2, V3. And we have these same changes, that's T inversion and ST depression, on left ventricular hypertrophy in lateral leads. That's V5, V6, 1, and AVL. By the way, do you remember the Sokolov-Lyon criteria for left ventricular hypertrophy? Well, we have our normal R progression pattern. So we have S that's very large at V1 and we have R that's very large at V5 and V6 to a point that the sum of S in V1 plus R in V5 or V6 is greater than 35 millimeter height. That's an amplitude criteria. Remember what's the criteria for left axis deviation? The lead vector, the final vector or average vector is on the northeast quadrant, that is between -30 to -90. So therefore, 1 shows positive QRS while the overall QRS axis on 2 and AVF are negative. A final ECG criteria that if you still have possibility to commit to memory is presence of septal Q waves, also referred to as apical pseudo Q waves. So put it simple, left ventricular hypertrophy, left ventricular strain pattern, left axis deviation, left atrial enlargement, and pseudo-septal Q waves. Okay, what is the first line for the treatment of hypertrophic cardiomyopathy? We begin with negative inotropes. Now, what are the most important examples of negative inotropes we use in this condition? Beta blockers, non-dihydropyridine calcium channel blockers such as verapamil, and a class 1A antiarrhythmic drug, disopyramide. If you remember from the antiarrhythmics, one of the class 1A drugs is highly contraindicated because of the side effect being heart failure, and that was disopyramide. Here, the negative inotropy is what we are looking for, and therefore we use these medications. How about use of diuretics? Remember, we don't use diuretics in the obstructive type, and we can use them with a lot of caution in the non-obstructive hypertrophic cardiomyopathy. We mentioned arrhythmias are possible in patients with hypertrophic cardiomyopathy. So answer this case. A patient with hypertrophic cardiomyopathy has an ECG reading that shows no P waves and irregular ventricular response. What is the drug of choice for rate management? This is AFib, and we said we cannot use digoxin in hypertrophic cardiomyopathy. So remember, for the rate control in hypertrophic cardiomyopathy, we use beta blockers. That is the first choice drug anyways. Now, if the patient shows no response and is refractory to medical management, what is the next step? Either myomectomy or alcohol septal ablation. Another very important question, what are the indications for ICD, the implantable cardioverter defibrillator, for patients with HCMP? Given the fact that HOCMP patients have the risk of sudden cardiac death, any symptomatic patient with HOCMP, that is septal hypertrophy, requires ICD. Other indications are any patient with hypertrophic cardiomyopathy with arrhythmia, especially ventricular tachycardia and ventricular fibrillation. On the other side, if a patient with hypertrophic cardiomyopathy had a non-sustained VTAC, we use ICD as a prophylaxis for preventing sudden cardiac death of arrhythmia. If all fails, the patient requires heart transplantation. Also remember, myomectomy or alcohol ablation is only indicated for the obstructive type, that is the septal asymmetric hypertrophy. For the non-obstructive hypertrophic cardiomyopathy, we do not get to use ablation or myomectomy logically, and so if they fail the medical management, the next step will be heart transplantation. Now, we mentioned a couple very important epidemiologic facts. One is that hypertrophic obstructive cardiomyopathy is the most common cause of sudden cardiac death in infants, and it's an autosomally dominant mediated genetic condition. And for this, we need to know about screening. What are the recommended screening? Any patient with hypertrophic cardiomyopathy requires a screening of the relatives by transthoracic echo. If they are teen, they are recommended to get this screening every once a year. But if they are neither a teen or an athlete, they can screen once every 5 years. We also consider genetic mutation testing, especially when we have known mutations. Now, I would like to finish this episode by a very important question on the ways to differentiate hypertrophic cardiomyopathy from athlete's heart. Why is this important? Because many professional athletes also have concentric hypertrophy, and you may see them in a doctor's office visit asking you about the risks of arrhythmia, sudden cardiac death, and syncope. So the first question is compare and contrast ECG findings in athlete's heart versus that of hypertrophic cardiomyopathy. Both conditions show left ventricular hypertrophy. However, only hypertrophic cardiomyopathy also shows other findings we mentioned, including especially left ventricular strain or left atrial enlargement. That brings us to another finding, that left atrial size is normal in athlete's heart. Now, we have an important echo criteria of the pathologic versus normal athletic hypertrophy, and that's the thickness of the left ventricular wall. The cutoff number value is 15 millimeter. If it is thicker than 15 millimeter, it cannot be normal athlete's heart. It is hypertrophic cardiomyopathy. Do you remember which one could have family history? Of course, the cardiomyopathy. Do we have septal hypertrophy in athlete's heart? No. As you remember, I mentioned the asymmetric septal hypertrophy is seen in the obstructive type hypertrophic cardiomyopathy, but not in athlete, in which everything is symmetric. Also remember that the intracavity size of the left ventricle is slightly enlarged in athlete's heart, but because of the concentric and asymmetric hypertrophy, the left ventricular cavity size is slightly decreased in the cardiomyopathy. And finally, athletes do not have left ventricular diastolic failure. So in summary, you have a patient with exertional symptoms and a diamond hole systolic murmur at Erb's point. You perform the echo and you diagnose based on the echo and ECG findings. Remember not to use positive inotropes, diuretics, vasodilators, ACE inhibitors, spironolactone, and advise the patient to avoid dehydration and vigorous exercise. Manage with beta blockers, preferred to calcium channel blockers, preferred to disopyramide, preferred to myomectomy. If all else fails, patient becomes candidate for heart transplant. Know the indications for ICD, screen the family, and differentiate from athlete's heart based on what we discussed. And this is hypertrophic cardiomyopathy.